All right, good afternoon / good morning, depending on where you are. This is Maeve, and I'm realizing I have an echo problem. Just a second.
Hello, this is Caleb.
Hey, Caleb, this is Maeve. Am I echoing still?
I don't hear an echo, but I had just had to call in again because I was pushing my speaker button and not my mute button. But no, you sound great.
Happens to the best of us.
So I know it's a little after, and I know a bunch of people are going to be out today for the Western Region Flex Conference. So if we'll go ahead and get started. I know we've got a lot of material to cover because we took up a bunch of your time last week with logistics and foundational things. So I will let you just take it away, and those who are not able to join us live will be able to catch the recording on Moodle shortly.
All right. Perfect. That sounds great. Well, this will be a nice small group. Welcome, Mary. I don't know if you were able to listen in with Stephanie last week, but it's great to have you on. And then it looks like we've got Melissa back from Missouri and Jack from Montana. Perfect. So what I wanted to do today was talk a little bit more in depth about the options for alternative payment models. And I'm going to go ahead and pull up my screen here. Last week, we just went over an overview for those of you who weren't able to join us of what folks were hoping to get out of the program and how the course is set up to work. Again, we want to keep this really interactive, so as we go through the program today, if you have any questions, concerns, you've got a little hand raise icon up in the top toolbar, or feel free to push *2 to unmute yourself or type into the chat box. The nice thing about having a really small group is I think we can have a pretty in-depth discussion today if there are any questions that folks want to talk about. So let me go ahead and pull up my screen. All right. So we'll go ahead and share this. All right, so hopefully in a second here, everybody can see my PowerPoint. There we go. All right, so today we wanted to focus on a couple of things. One, we wanted to recap the APM options. Essentially throughout the U.S., there's 4 models for Medicare beneficiaries, and we are going to focus a little bit more on Medicare just because we've got a national audience. So a couple of you mentioned last week that in your states you're seeing some different options with Medicaid and private pay as well. The option that works out, and here's where the spoiler comes in, is that really the ACO is the best option for most critical access hospitals. So we'll talk a little bit more about ACO requirements, and then we'll talk a little bit about the TCPI program. I wasn't planning to include this originally, but as we were going around the circle last week, a lot of you said that you wanted to learn a little bit more about the TCPI program and how it fits into the world of value-based pay. So I'll take a couple of minutes to talk about that as well. And then we wanted to shift to talking about results from the survey, just to get a kind of finger on the pulse of where states are as a whole. And the reason that we felt the survey would be helpful for you all to send out was, you know, we're getting a lot of questions about how do state offices of rural health support value-based pay work. And one of the key components of value-based pay, as I'm sure you all have heard, is being able to have the number of beneficiaries, which is, depending on the model, 150 to 5,000 at a minimum. And with value-based pay, because it's based on population health principles, typically the results are a lot more predictable and a lot more successful if you have a larger population of patients that you're caring for. And that's where state offices of rural health can be very vital in convening convening and facilitating that discussion, and possibly, again, helping with that economy of scale on technical assistance to support initiatives around value-based pay. So we'll really talk about, kind of based on the results of the survey, what can you do as a State Office of Rural Health to start supporting this work. And then in between now and next week, we'll have a template state assessment on value-based pay for you all to complete, just so that when you leave this collaborative, you can leave with a one-pager that you can share with your hospital CEOs, just to report on the state of value-based pay. And I think the idea here is really twofold. You know, one, to demonstrate that as a State Office of Rural Health, you're keeping in good touch with where the forefront of care is going, even though, you know, in rural health we're still having a lot of issues with access and CAH designation being threatened. You always want to keep an eye towards the future. And then secondly, I think by presenting a summary of these results to your hospitals, you're able to show, too, for those hospitals that are lagging behind and just kind of keeping their head in the sand, that there are people in the state who are being forward-thinking, so to provide a little bit of motivation and peer support for the hospitals as well. So that's what's on the agenda today. Is there anything else that anybody is just dying to cover, or any questions from last time that came up? Nope. Okay. All right. Well, feel free to put things into the chat box as we go along here. And the nice thing about today is we only have me, Caleb, Jack, Mary, and Melissa on, so it's a nice small group, and we can make it as interactive as we want. All right. So we went over this at lightning speed last time, so I'm going to slow it down a little bit today. And I think it's nice that we've got both Montana and Missouri on, two states that do have the option to do CPC Plus. However, this is more primary care focused. We'll talk briefly about what bundled payments are, just because you might have some rural PPS that are participating in this. We'll talk about what the Mips program looks like and some of the survey results that we got back from our CEHs on this, and then a little bit about the Medicare Insured Savings, or ACO program as well. All right. So in terms of the current landscape of the Quality Payment Program, we all know that the Quality Payment Program was created as a result of macro legislation about 2 years ago now. Time flies. And basically what it did was it did away with the PQRS, or the Physician Quality Reporting System, that a lot of hospitals, I think, got burned on. I know I was at the Oregon Office of Rural Health at the time when CAH hospitals started having to report PQRS, but everybody forgot to tell the CAHs that they were no longer exempt. So a lot of folks didn't end up reporting. And when we look at the survey results, we did ask a question about Mips of the CAHs, and I think that's a very it's an interesting thing, and I'm curious to hear what y'all's input on it is, because it looks from the survey that we had a lot of CAHs who did not report in QPP, which is never good for their reimbursement. So anyhow, under the umbrella of the Quality Payment Program, physicians were asked to, or were sorted into kind of 3 buckets depending on their reimbursement models, or we should go with 4 buckets really. So the Quality Payment Program was Medicare's kind of bold move to move even more clinicians towards value-based pay. RHCs and FQHCs are currently exempted from the program. And then we have 3 other categories. So the merit-based incentive payment system is kind of like the new PQRS plus meaningful use. And that grouped all of the clinicians who kind of decided that they weren't going to do anything proactive to be in this bucket. Then we have the Mips Apm. And the Mips Apm is for those who have been kind of progressive in moving towards an alternative payment model, but are not fully in a risk-bearing alternative payment model. So an example of this is Track 1 ACOs. Those are no-risk ACO arrangements, so those fall under the Mips Apm. And then lastly, they had advanced alternative payment models, which include CPC plus bundled payments, and then usually your tracks 1+ through 3 ACOs, as well as next-gen ACOs. So this is the general overview of the landscape that we're looking at. And I saw something come in on the chat box. So I'm going to try and check that, but it looks like it's disappeared from my screen. and I think that was Jack's clarification of not all flex programs are part of state offices of rural health, if I read that right. Yes, I absolutely, my good friends in Montana, I worked a lot with Jamie when she was there, and she definitely did a good job letting me know y'all were at the Hospital Association, so thank you, I appreciate that. So one of the things outside of payment that the QPP is doing is trying to push consumers to high-value care. A lot of you have probably heard of Physician Compare. The unfortunate thing about Physician Compare is even when we have outmigration in rural areas and lots of problems with access to care, Physician Compare, while it can be empowering for consumers, I think may also send some challenging messages. So if you are an RHC physician or an FQHC physician or a physician who's a low-volume physician, as many of our rural physicians are, you show up like Dr. Leslie Lane here on Physician Compare with no data about your practice. So not only is the quality payment program changing the way we do reimbursement, it's changing the information that goes out to the public. So the idea is that if you are a rural practitioner, a lot of times routing yourself into either a Mips Apm or a full-on Apm is going to put you into this bucket, and you will have data collected on you, which is a good thing, because if you saw a one-star provider, you probably wouldn't be thrilled about seeing them. But rural clinicians can participate in Physician Compare by getting data through an ACO or other kind of alternative payment model where they're grouped in with other physicians. So it offers a way to start playing this quality game and start having that affect the positive reputation of your practice. The other thing that's challenging for a lot of our rural clinicians right now, I noticed in the survey a lot of hospitals reported that they were exempt from Mips, which I'm interested to get a little bit more insight from you all on. But if you're reported or exempt from Mips, you might think that that's a good thing, but really your adjustments are not going to keep pace with inflation if you're exempt from Mips. So finding a way to participate in value-based pay and be able to get some of these positive incentive payments is actually a very solid path forward if you can score well in them. We've seen a lot of folks kind of get on the bandwagon of value-based pay with mainly ACO participation, also some CPC plus participation, and now we have almost 923 ACOs, and that's about 30 million lives that are now covered. So I think one of the other reasons it's really meaningful as a state flex coordinator to be involved in this discussion right now is that you can kind of help shape the trajectory of what those options for rural hospitals are and rural communities in general. A lot of folks are getting rolled into ACOs with their nearest urban health center, and that can be a really good thing, or it can be a really detrimental thing. It really depends on how you set up the structure of your ACO. So we've talked a little bit about the climate already, but we don't know exactly what's happening. We talked about the fact that RHCs and FQHCs are exempt from value-based pay at this point in time, but we're not sure where that's going. The CMS Rural Health Strategy that came out at the beginning of May when we were all at NRHA was focused on 5 different pillars, but one of those overlying principles that they included was the idea of accountability in care. And right now we know we don't really have a standardized rural model for accountability. So by taking the leap into value-based pay, rural's making a stronger statement about the accountability of care that will help shape this agenda in a more proactive way. So let's talk about bundled payments first. Bundled payments are payments that are pertinent to a group of providers and related to a DRG for which that group of providers affects. So bundled payments are not a great model for critical access hospitals because you're only getting a set amount for a given DRG. And you can select to participate in as many of these DRGs as you want, but for most CAHs this isn't an option because it ends up being a worse deal than your cost-based reimbursement. Comprehensive Primary Care Plus is another really common is another really common option available for a lot of folks in 13 different states. So Montana is one of those states, Missouri is one of those states. I don't know, Jack or Melissa, have you heard from or gotten any feedback from anybody participating in CPC Plus, how they're liking it? No. And it may not be just that you all have heard from them, just because this is a primary care-based model. It was an evidence-based model that started in the Innovation Center and was scaled up. It focuses on a multi-payer approach in theory. One of the challenges for rural with the CPC Plus program is that even though it was multi-payer, there was no stipulation that a given payer had to contract with all CPC Plus participating practices. So we actually, from our program, graduated a lot of Montana practices into CPC Plus. And in following up with them post-graduation, we learned that a lot of the commercial payers were refusing to contract with the rural because they didn't feel like their volume was meaningful enough. So CPC Plus is a really challenging option for rural. It can be great for larger practices who have a more robust beneficiary mix, but it requires a lot of very prescriptive care delivery processes, and it's only open to fee-for-service primary care providers. So we're more including it just so if hospitals mention it to you, you know what it is, since a lot of our critical access hospitals will have non-RHC clinics. There is a place where CPC Plus can overlap with ACOs, so just because a hospital has a CPC Plus clinic doesn't mean they can't participate in an ACO. So that leaves us with two main options for most providers. So most of your critical access hospital providers are either going to be part of the straight-up merit-based incentive payment system, or they're going to be part of a Mips Apm or full-on Apm. So we'll talk a little bit about kind of the two areas that most rural falls into at this point. So Mips is just based on 4 categories of cost, quality, advancing care information, which is now called interoperability, and then improvement activities. So that's the typical Mips program. And I don't know, from the 3 of you on the line, if you want to type into the chat box, how involved were you all from your Flex perspective with giving any technical assistance on Mips or getting feedback on Mips for CAHs? And we could actually, we've got like 3 of us on the line, so maybe we'll just go around in a figurative circle. So it sounds like from Mary, Idaho wasn't involved in any Mips technical assistance. What about you, Jack? Okay, Flex has not been actively involved. And Melissa, I'm trying to read your comment, and it's kind of going off the screen here. It says Flex coordinators might have been involved.
I think most of the Mips TA support was done through the QINs or QIOs, from what I, from the experience that I've had.
Mm-hmm. Yeah, well, and it is really interesting how that rolled out, because I know when, like with PQRS, when I was in Oregon, I was getting a ton of calls from folks wanting assistance on PQRS. I think mainly because, you know, we were good people to call, we were the go-to, but then, yeah, a lot of the actual technical support was fed back to the Quinn QIOs. So I guess, just to kind of tailor this discussion a little bit more, how familiar do you all feel with the Mips program and its impact to CAHs? And feel free to type into the chat box too. It looks like a couple folks are chatting. Okay, so not as much familiarity. So I'll spend a little bit more time talking about it, just because it does have a pretty large impact to rural hospitals, and I think it can be kind of challenging for rural. So Mips makes you report on 4 different categories. versus if you're in a Mips Apm, you only report on 2. And it's good to hear that there's some QRIOs that are doing a really good trainings out there for rural as well. So let's just talk about straight up Mips and what the categories are. So right now we're in 2018, and this is the second year of the Mips program. So the Mips program affects all physician fee schedule payments that are going to rural hospitals. They do have a volume exemption threshold, but most CAHs, because of the volume of patients they see, don't meet that volume threshold to have an exception. So for the past, or for this year, they upped that to 200 Medicare beneficiaries and $90,000 of physician fee schedule payments. So most CAHs are billing more than $90,000 on the physician fee schedule. So they're going to be part of this program. So this year, Mips gives you a score out of 100 points based across these 4 categories. They're not evenly weighted. So quality, which are a lot of like NQF measures, similar measures that kind of similar measures to what you might see in the MD-QUIP program. There are some things on there like pneumonia vaccination, flu vaccination, those types of kind of primary care related measures that also come up in hospital care, but then there's a lot more focused on the outpatient side as well. So clinicians get to select which quality measures they report. There's over 100 to select from, and you can report as a group or individually, but ultimately you're given 50 points maximum for scoring well on the quality of care that you provide. The second category is cost, and this is really new because this is CMS's way of holding everybody under the physician fee schedule accountable for costs. So Medicare looks at an attributed number of beneficiaries and says, for these services that you provided as a physician, we are judging that these patients are yours, so to speak, either because of the diagnoses that you saw them for or because of the number of times that you saw them. And based on that, we're looking at that beneficiary's total cost of care, even if they were in a different hospital down in Arizona, if they went to see a specialist in an urban area, we're going to hold you accountable for the cost of care. And so here they kind of have decile benchmarks. So if you are in the top scoring decile, meaning your patients cost CMS the least, then you get 10 points. And if you are the most expensive provider, you get 0 points. And I just saw a question come through from Mary. How many quality measures do you select? So these 50 points are based on performance across 6 quality measures. And you get to pick what 6 you report. So there is some flexibility there. The unfortunate thing here for rural is that because a lot of rural hospitals are having more trouble with their EHR, there's a couple different reporting methods that you can do here. You can do claims-based, you can do EHR, you can do registry reporting. But because rural, since they haven't been forced to report for as long, usually their EHRs and the way they're collecting data isn't as refined. So they tend to struggle more on the quality scores, not because of the actual quality of care, but typically if you have an EHR, I mean, I think we've all probably heard this from our hospitals, that's suboptimal, or if you have, you know, a claims process where not all the diagnoses are getting on the claims, your score is going to be lower there just because of documentation issues rather than quality of care issues. So the quality section does tend to present a challenge for rural. We talked about quality. We talked about cost. Improvement activities. This is kind of like the participation category, so you can get 15 points for this. And these are activities that are evidence-based to contribute to improvement in health outcomes or cost of care. So there's about 90 different improvement activities that you can pick from. If you're a small practice, you pick 4 medium or 2 high-weighted activities. And this is really like, this is really kind of where it gets to be like playing some kind of board game here, because there's all kinds of activities that you get points from. And these are usually pretty easy to check off as long as you're participating in some kind of improvement initiative. And then lastly, advancing care information is that final category, and this is worth a quarter of your score. And this is a little tricky because it's like meaningful use, but it's a little bit more performance-based. And it focuses on not only yes or no, are you using certain processes with your EHR or state reporting registries, but to what degree are you using registries? So an example on advancing care information is you've kind of got these 5 base measures that account for your score. And if you miss one of these base measures, you get 0 points in this entire category. So you get, a certain number of points just for having these 5 measures in place. But beyond that, you are judged on performance on some of those measures. So for example, yes or no, do you have a patient portal is a base measure. So yes, you get a couple of points for that. But then it asks, what percentage of your patients are using your patient portal and have signed in the past reporting period? So things like that are a little bit tricky. It's asking not only does the hospital have this capability, but how many patients are engaged in this. So these are very tricky categories to do well on for rural. In the past, we haven't had to look much at cost of care. We haven't had to look as stringently at quality. Improvement activities, I think rural does a lot of this, and this is one area where they might get ahead of urban. And then advancing care information can also be a challenge. For anybody who wants kind of more in-depth on each of these categories, we could spend all day talking about these. It sounds like a couple folks have quins that have done really good work on this, but this is a great, I think, cheat sheet from the QPP program that goes over all of these categories in depth. So you can find more information here. So now that we've talked a little bit about the scores, let's talk about the consequences of the score. So even if you got a really good score, let's say you got 80 points out of 100, that's a solid B, a pretty solid performance for your first year. You're then graded on a curve. So if everybody else gets a score of 85 on average, but you get a score of 80, you're going to fall to the left side of this curve. And what CMS has said is with MIPS, they're going to try and keep the good providers who are high achieving in business, and they're going to try and drive the low scoring clinicians out, so to speak. So this can definitely be a challenge for rural for a number of reasons. We talked about why some of the categories were challenging to rural in the last slide, but I think one of the other things that's really crucial to bring up here is just the volume. So one of the options that you can help convene as a state flex program is virtual group reporting to help build that volume. For quality scores, if you only have 20 patients, that's an eligible population for a given measure. If you miss one of those patients, you're automatically knocked down to 95% performance. But if you have 100 patients and you miss one patient, it's only 99% performance. So it's easier you've got a little bit more grace to mess up with a larger patient population. And there's a greater chance that you're going to land on the right side of the curve just by pure statistical methodology. So you want to make sure that all of your rural hospitals that are reporting are scoring on this right side of the curve. And the challenge here is that MIPS and Mips Apm providers have different methodology to get their scores out of 100 points, but they're all competing on the same curve. And it's a lot easier to do well as a Mips Apm. And we will go more into depth in that a little bit later in the curriculum. But the bottom line here is that practices who score below average on their 100 points are going to get negative payment adjustments, and this can be up to negative 9% on their physician fee schedule reimbursements. Or they can get positive reimbursements, again, up to plus 9%. So you definitely want to be on the right side of the curve. And people who choose not to participate but are eligible to participate are going to get the lowest or the greatest penalty. So that's another reason where you really want to make sure that if your critical access hospital physicians are eligible, that they are reporting, because sitting this one out is really going to hurt on the reimbursements that you're getting. So we looked at the data that you all had sent out in the surveys, and I know not everybody had a chance to send out the survey, but looking at the number of hospitals that responded, we had, I think, 104 hospitals respond to the survey that we sent out about value-based pay, or that you all sent out, and almost half of them, 49 of those 49 of those critical access hospitals didn't report MIPS. This means that in 2019, they're all getting a negative 4% adjustment on their physician fee schedule for their anything that they're billing method 2 from the hospital. So this is definitely going to hurt. I mean, we know that rural hospitals typically have a less than 1% margin anyways, so getting a negative 4% on their physician fee schedule reimbursements is not going to help. And I think, you know, this is similar to what happened with PQRS. I think there was some misunderstanding about whether or not rural hospitals needed to participate. So hopefully I think this is another area where, as flex coordinators, we can be part of the voice on helping people kind of get into participation here. I'm curious from you all, I know you said you weren't doing a ton of technical assistance around MIPS, but do you know, I mean, do these results with about 50% of hospitals not reporting MIPS, do they seem accurate to you, or are you surprised by this? No, and one of the things that we'll do at the end of this, yeah, unfortunately this isn't surprising. I think there was a lot of challenges with getting the message out. So I think if you do nothing else under value-based pay to support rural hospitals in your state, making sure they understand the reporting requirements is a huge thing. And I know when I was with the Oregon Office of Rural Health, one of the things that we did was partner with, we had Health Insight as our QIO to be able to kind of do a rural-specific webinar. I talk with, you know, hundreds of clinicians all over the U.S., and it's always surprising to me how many folks are like, MIPS what? But participating and getting the full reimbursement is so crucial. And this was from the survey results. Again, we're going to post these on Moodle. The folks who did report, we only had about 4 people who, about 8 people who are, for hospitals, I guess, who said that they actually reported a score. In 2017, you had the option to just kind of check a box and sign into the system and report one thing. So 2017 was the test year. You still got a negative penalty for not reporting. But 2018 is really the performance year where we have to do all 4 of those categories. So most folks, even if they did report, like these people who scored 60%, there's no penalties as long as you reported something for 2017, but this is not going to fly in 2018. They're not going to be doing well if you're scoring 60, 65, 68. I would even be worried about practices in the 80s right now from what I've seen and talked to folks about how they're scoring. I think mid-80s, if I was a guessing person, mid-80s is probably about the average MIPS score for 2017. And then you do have a couple folks who in the extended response think that they were exempt. They weren't aware of their MIPS score. You know, they think they have low enough volume. There's a slight chance that, you know, some really frontier hospitals have low enough volume that they didn't qualify. Some folks got waivers. But I think these extended responses, too, show that we really need to be in action on this as a rural health community and in exploring kind of and just educating what should folks be looking at for value-based pay. You know, most people, most hospitals are going to be involved in this. So we've talked a little bit about how folks did for MIPS in general, and I mentioned that under MIPS there was 2 options. So there's just the straight-up MIPS program. It looks like we're getting a question. Let me pull that little box up. Caleb, can you read the question that just came in?
Yeah, Mary was wondering if you could clarify the payment impact, if any, for low-volume hospitals.
Yeah. So if you are a low volume hospital and you fall below that threshold of 150 beneficiaries, or it was $50,000 in billing, you get that just slight adjustment that was decided under MACRA. So I think you get like a 0.5% increase each year to your payments if you're exempt from the physician fee schedule program. However, if you are not exempt and you didn't report, then you are getting that full negative adjustment. So it was negative 4% if you didn't report in 2017, and that hits your payment 2 years later. So that's similar to PQRS, where the year that your performance year is 2017, but that doesn't impact your reimbursement until 2019, and that is only for your Part B physician fee schedule payments. So if you're billing method 1 as a CAH, you'd fly under the radar here since you're doing the facility billing. But method 2 usually has to participate. When I was in Oregon, most of the hospitals I worked with were billing method 2. I don't know what the mix is in Idaho or Montana or Missouri. So that could be another thing or another strategy that CAHs might want to look at if they think that there's just no way, no how. But of course, that requires a whole rework of the billing. So I don't know that I would advise that. Does that help, Mary? Okay, perfect. All right. So given that MIPS is kind of challenging for rural hospitals, we're seeing more and more folks take a second look at the Medicare Shared Savings Program, which is also known as an Accountable Care or ACO organization. So there's 5 different options here to pick from if you are a rural hospital. So there's 5 tracks. So there's track 1, which is not a risk-bearing model. And the thing with rural hospitals is pretty much any rural hospital you talk to is going to need to partner with another entity to be in an ACO just because of the number of beneficiaries. But even if you can get above that 5,000 beneficiary threshold, chances are that statistical variation is still going to be of impact to you. So if you have a small ACO, numbers don't really get predictable until you hit like at least the 20,000 beneficiary threshold. You probably don't want to be in a risk-bearing track. So track 1 is a great starter option for getting into an ACO because you're eligible for up to 50% of the shared savings going back to your facility or your ACO. And the nice thing about those savings that go back is, depending on how your ACO is structured, whether you're for-profit, nonprofit, those savings for most of our ACOs that I see graduate from our program, it's structured as just like a nonprofit board. They go back to the mission of the hospital. So Dayton, I think, is a really good idea. Dayton, Washington, their Columbia, they have a Columbia Magnolia Evergreen ACO, and they got shared savings back because they reached the benchmark threshold, and they were able to reinvest their shared savings in hiring a psychiatrist for their community, which was pretty cool. So 1 is the only non-risk-bearing track for an ACO. Track 1 Plus is kind of like the training wheels for an ACO, and as you progress along these track levels, the big difference is that you have to reach increasingly high targets for shared savings, and with those higher targets, you get to, you're also eligible for a greater portion of the shared savings. So like looking at track 2, you can get up to 70% of the amount that you save back to your facility versus in track 1, you could only get 50% back. So you up the stakes as you go up each one of these ACO levels. And then finally, the next gen ACO, there's not only a difference in the amount of shared savings you can get back there, you also have a little bit more flexibility in how you provide that care. With any ACO, you have the ability to use what are called waivers, and these are things where a lot of times the certain Medicare regulations that didn't make a whole lot of sense to us. For example, if I'm a hospital, I can tell my patient has mobility issues, but I've got to discharge them anyways. If I build them a ramp to get in their home, it's enticement, and that's, of course, illegal and completely out of compliance. But with an ACO, you can provide a waiver, and you can help them build a wheelchair ramp to their home, and it's fine because you've got this care waiver in place. So ACOs are nice, and then they give you a little bit more flexibility in how to provide care to your patients. The summary that you should kind of be getting from this slide is that there's 5 different options for participation in an ACO. Medicare is about to release another round of guidance on what options are going to be formally available for 2019. It's probably going to look very similar to these 5 tracks. The overall idea here is that once you have an ACO, Medicare says you've got a given number of patients who are yours in the ACO. And with that, this given number of patients on average cost a certain amount for care last year. If you can beat that benchmark by at least 3%, we're going to give some of your shared savings back to you. One of the questions that I get really commonly from both RHCs and critical access hospitals is, what about my cost-based reimbursement? Am I forfeiting cost-based reimbursement if I go into an ACO? And the answer to that is no. All your existing reimbursement stays the same. So you still do your cost report the exact same way that you would have if you were not in an ACO, whether you're an RHC or critical access hospital. The difference is that if your cost of care goes down, you get to reap some of those shared savings. So those are kind of the highlights of the ACO. We'll talk a little bit more about the specific elements. So starting up, up at the top with where did ACOs come from? ACOs are getting to be a little bit more mainstream now. It's been about 8 years since the Affordable Care Act passed and provided for the introduction of ACOs to reduce the cost of care for Medicare fee-for-service. The idea is that an ACO is a group of Medicare providers. So, again, your pediatricians, your folks who don't take Medicare are not part of this model at all. And this group of clinicians agrees to be accountable for the Medicare fee-for-service beneficiaries that they're working with. So the idea is that the ACO drives collaboration and coordination. And this is another point that I like to really focus on is I think for rural hospitals, there's a lot of strength in banding together in an ACO. It really offers more incentive to work on your care coordination, and it provides shared savings for realizing results from this as well. The idea is that not only do you change the way you deliver care in the ACO to be increasingly focused on care coordination and evidence-based care, you're also really looking at your patients not only as individuals but as a population. So you want to be able to kind of have programmatic insight to be able to direct an ACO. So I think a lot of us on the call have a background in either hospital administration or public health, and I think that administrative skill set can be really useful to hospitals as they look more closely at the ACO. It's a big shift to change from looking at patients on an individual basis to looking at a population of patients and really looking at the process behind things. So I think one thing to keep in mind too with ACOs is that it's culture change as well as delivery system change. It's not just a reimbursement change. So as far as looking at how to form an ACO, I think this is another area where hospital associations, state flex coordinators, whatever convening entity, rural health associations, whatever convening entity you have in the state can be really helpful to help rurals get to know each other. And ACOs take a variety of forms. You do have the big health systems who, as a single entity, sign up as an ACO. But there's a couple different ways this can look. We have networks of individual practices. IPAs can form ACOs. also have, we have hospitals right now who partner all over the country to get together to form ACOs, and they go through a whole process to form an ACO entity. Federally qualified health centers can participate, rural health clinics can participate. ACOs are available to a large number of healthcare entities. It's just a matter of making sure that you have attributed patients. And attribution in the ACO is just a fancy word for how CMS assigns you beneficiaries. So as far as what this looks like, you need at least 5,000 Medicare fee-for-service patients to be part of a Medicare ACO. So I think we know that most of our rural hospitals don't have 5,000 Medicare patients, so most of them need partners in the ACO. And the way you get attribution is by providing primary care services. So a lot of hospitals are kind of the ringleaders for ACOs because they've got more staff to help manage data. They might have more capital for any changes that need to be made in the delivery system, but you can't do this without the primary care clinicians in your community. So that's another thing that I think is another really useful role that Flex coordinators can play in this. Even though the Flex program is a little bit more hospital focused, I think being able to network with other folks in your state who have access to the primary care side of things can really help start the discussion for rural hospitals as well. When you enter an ACO, you typically sign on with Medicare for 3 years of being in whatever track you sign in on. And, you know, I think one of the things that's really fundamental here is there's just a huge diversity of who can form an ACO. And we're going to go more into this later in the collaborative. But I just want to open up the idea that, you know, this can be an IPA that forms an ACO. It can be a network of hospitals all over your state. It can be, you know, the hospital association who signs folks up as an ACO. There's just a lot of different ways that this can go. So once you get into the ACO, you are still doing quality reporting. So a lot of the work, I don't know if I have any folks on here who have been the MVQIP leads in your state or maybe the SHIP grant program leads in your state. The work that you've been doing there to help get practices ready for ACOs I think is hugely meaningful, helping them look at value-based care, helping them look at reporting and quality measures. Those are great training wheels. I know when I was a Flex coordinator, MVQIP participation, we were at 100% in Oregon, but it was hard to hold people there. People are like, well, why am I practicing this quality reporting? I think, you know, being able to start managing the process of quality reporting is hugely important to being able to participate in any value-based care system, whether it's an ACO or other system as well. So those are kind of the 4 options that we talked about. CPC Plus, bundled payments, Mips, and then overall ACOs. Are there any more questions about those before I shift to talking a little bit about the TCPI program and resources to prepare? Nope. All right. Well, we'll go ahead and shift to talking about how you prep for these. So one of the things that CMS was noticing after the Affordable Care Act had passed and after they had put out these innovative models is that people were very timid about not only signing up for the ACO models or any kind of alternative payment model, but also even making changes to delivery reform. So the CMS Innovation Center opened up a new funding pathway called the Transforming Clinical Practice Initiative. And the Transforming Clinical Practice Initiative is, I think, more than a quality improvement collaborative. It's a national program where over 31 practice transformation networks are available throughout the nation. You can see here on this slide, depending on what state you live in, you've got a couple of different options for practice transformation networks. So we've got beautiful Missouri, Idaho, and Montana. In each of your states, there are 2 PTNs available. So for example, I know that in each of your states, National Rural, our nonprofit, is one of the practice transformation networks. We're available. And then it varies by state what the other one is. I think in Washington and Idaho, your other option is, I think it's WWAMI out of Washington State, provides kind of a pediatric focused PTN, and then Missouri, I actually don't know what the other option is there. But there are options for which PTN you want to, or your clinics want to enroll in, and they have different focuses. So like our PTN is really focused on getting folks into alternative payment models. Other PTNs are really focused on specific processes of care, for example, psychiatric care transformation or things like that. And Jack, I just saw that message pop up. I think it was a little delayed, but I think the WWAMI PTN, and I can't remember what that stands for, but it's that center that does, the West Wyoming, Washington, Alaska. They are rural. They do a lot of rural work. I can send you the information afterwards. But PTNs work with individual healthcare entities. So like in our national rural PTN, we're working with over 300 hospitals and clinics throughout rural America to help them get ready for alternative payment. And the idea is that we're not only helping with kind of education and basic quality improvement, we're helping practices explore what their options are in value-based pay. So in our particular program, we help train care coordinators. We have an online self-paced training for folks to get comfortable with motivational interviewing. We're really focused on billable interventions. I think any rural health entity right now is looking at what's helping or happening all across the country with kind of the fragility of the rural healthcare system. So financial health is a huge thing that we look at. So we teach practices to bill for annual wellness visits, to bill for chronic care management, as well as psychiatric collaborative care management and behavioral health integration, which are two innovative models that have come out of the Ames Center at University of Washington to help primary care providers manage behavioral health care. I would say psychiatric collaborative care is really similar to Project ECHO work that may be going on in your state in terms of having a PCP who's treating a patient, but they're getting advice from a specialist. And then behavioral health integration is kind of like chronic care management for people with milder behavioral health issues. So we teach how to bill all of these things. Most of these are outpatient codes. So we do work with a lot of hospitals that have provider-based clinics to help them get going on these codes. If you'd like more information about any of these, actually, we partnered with TASC to do a webinar. I believe it was all the way back in March on what some of these billable interventions look like, and we'll post that on the resources section of the Moodle page as well. In addition, we also help practices do financial modeling around alternative payment model choices and learn what's out there depending on, kind of how a critical access hospital is set up. Do they have a clinic? Do they need to get in with somebody else who's already doing primary care to participate in an ACO, things like that. And then we also help with coding and risk adjustment. As flex coordinators, have you all, or maybe this falls under the SHIP program a little bit more, but have you all done any work with helping practices look at their risk coding or HCC scores? No. And I'll show a data source in a little bit here that I think is really interesting, that kind of gives a good profile of what states or how states are scoring on this, that can be really useful for judging if there's a need for this. So the theory behind transforming clinical practice and the approach that we bring is that there's kind of three elements that you really want to focus on to be successful in value-based pay. And I think these areas align nicely with some of the areas in the FLEX program. Maybe not prevention as much, but I think there's opportunities under both FLEX and SHIP to look at population health data and how hospitals are playing a role in this, and then care coordination as well. So if you can do these three things well, care coordination, prevention, and get a really accurate picture of population data, you're very likely to do well in an alternative payment model. So these are kind of, these three broad categories are kind of associated with some other areas as well. So quality metrics. All alternative payment models have some accountability for quality metrics, whether it's bundled payment, CPC plus, Mips, or ACOs, you're going to be accountable for quality metrics. So making sure that your hospitals are putting emphasis on being able to get accurate data is huge here. There's a lot of alignment in going into an alternative payment with quality measures. One of the things that we talked about earlier was you get kind of more of a volume, so there's a little bit more margin of error there, or cushion for error. And a lot of the alternative payment models, as opposed to just general MIPS, are more forgiving in terms of having fewer metrics or having metrics that are easier to report. You can do the same metrics for your specialists and your PCP if you're in an ACO, for example. So that really helps with the quality metric portion of things. We talked a little bit about the beginning about kind of the rise of physician compare and how rural is basically not going to be represented on physician compare. So if you participate in an alternative payment model, you're much more likely to be able to show off kind of that good quality of care through participation. Any alternative payment model is going to hold practices accountable for costs. So, you know, not only is this present in MIPS, but the ACOs, obviously, if you can save on costs, you're going to get shared savings back. CPC Plus offers an incentive payment if you can save money on costs, and then bundled payments, obviously, you know, if you can save on certain DRGs, you get to keep that money. So being able to monitor costs and have a real sense for not only, you know, cost reporting and kind of the basics of RHC and CH reimbursement models is important to survival, but being able to do this in a proactive way and know how to maintain your costs while at the same time still getting what you need out of cost-based reimbursement is going to be a huge area of support. I mean, right now in the Flex programs, are you doing any work around helping look at containing costs for a population or care coordination? And this is an area we can take a look at more as we shift. The way we've set up this collaborative, the first couple webinars are focusing on just kind of the landscape and getting some preliminary data, and then the last two discussions are focused a little bit more around intervention. So we are going to talk a lot more in detail about some of these strategies to impact costs. One is really looking at your HCC coding, and then the other is looking at care coordination. The reason you want to look at coding to monitor costs is that in any value-based model, your costs are risk adjusted. So if you don't have accurate HCC coding or hierarchical condition coding, oftentimes rural undercodes, which means that to the federal government, rural beneficiaries look like they're incredibly healthy, but they're not. And then as far as looking at care coordination goes, you know that with sicker patients, if you can help them manage their disease a little better, they're less likely to have avoidable hospital admissions and things like that. So cost is another area you want to be taking a look at. Making sure your EHR capabilities are up to date. This is not only important for the quality portion of things, but also for the care coordination of things and EHR standards. I think one of the things that can be challenging for a lot of folks who want to participate in an APM is that you have to have a certified EHR. Not just any EHR, it has to be usually at least a 2015 level certification. So that's another thing to keep in mind too. And then lastly, you have to be willing to change the way you're delivering care. I think a lot of alternative payment models in their initial iterations got kind of a bad rap because people signed up for these alternative payment models but didn't really change the way that they were delivering care. So you heard about systems like Dartmouth, for example, that thought they were doing a great job of delivering care, and they were probably above average, but they didn't really change a thing when they got into the ACO, and as a result, they didn't see many shared savings. So you really have to be looking for hospitals that are willing to go through delivery transformation if they're going to be successful in any kind of alternative payment model. And I think this is another area where, as a Flex coordinator, you can have huge impact in terms of convening discussions, providing learning collaboratives. I know folks just submitted for another cycle of funding for Flex, but be thinking as you go through the implementation of those funds, what can we do to act as a convening body and really facilitate discussions around transformation to help practices get there. So the other thing that we like to emphasize is that transformation is financially sustainable. Anytime you're giving billing information, practices need a lot of technical assistance, and I think this is another area that you can look at under some of the finance areas with flex funding, is seeing how you can work in some training on how to make transformation financially sustainable. This is just an example of some of the population health codes that you can now bill for to help with preventive health and quality metrics as well as care coordination. So everybody sent out the survey, and I think we're going to leave it open until the end of this week because we only have about 100 practices that have filled it out so far. But we'll be posting a template that you can kind of use to analyze the results. Just to talk a little bit about some of the results that we're already seeing, most of the hospitals that we heard from responded that they don't have a value or a strategy in place for value-based pay, or they are just starting to implement it. So those are the folks that we're looking at over here. There's a huge need for folks to have a little bit more guidance to implement value-based pay. And so this varies a lot by state in the results. This is just results as a whole. So we'll be sharing that with you all uploaded to the Moodle site. We talked a little bit about the Mips data. Again, it's concerning that about half of hospitals didn't participate in Mips. This means that everybody who didn't report is going to get a negative adjustment on their physician fee schedule payments. We talked a little bit about the free response already. I thought one of the really good things that we saw in these results was that we have a lot of rural communities who are starting to do some of the work around transformation with providing health education classes, providing chronic care management, providing transitional care management, as well as behavioral health integration. So I think another thing that you can do to increase financial health is make sure that your rural communities are billing for these services, because historically a lot of these things, health education and chronic care management, have all been done as just kind of a community benefit type of service, and there's a lot of billable revenue out there. A lot of hospitals are saying they don't have a plan to manage costs, and I think that kind of rings true to our discussion a little bit earlier. So this is one of the things that we're going to address later in the curriculum with some specific examples of the work that you can do here. And then finally, looking at population health outcomes, this was another area where only 10 of the 100 hospitals who took the survey said that they've got documented improvement in some population health. So I think rural's a little late to the game here. This is a complicated area, but we definitely want to get more of our rural hospitals having really targeted population health plans. So as far as some additional data sources, we're going to talk about these as we move forward and kind of crafting more specific plans. But you can actually go online and see the exact number of traditional Medicare beneficiaries in a given county, and this can be really helpful in terms of being able to gauge how close your hospitals are to reaching the volume threshold. So this is a resource that we're going to talk about a little bit as you move into kind of the template and planning work for this. But be aware that's a resource that's out there. And then finally, looking at your quality use reports and your MBQIP data can also give some more hints as to where you are. So we're coming to the end of our hour. What we're going to ask you to do in